The most common question comes up in the exam. When you examine the chest from the back, you start with inspection. Inspect for any skin lesion or scars, cautery marks, or deformities, scoliosis, kyphosis, or kyphoscoliosis. When you ask the patient to take a deep breath, you see if there's any equal chest movement. والنفس محمد تمام. Well, you can see that the chest is moving equal bilateral. Palpation from the back. There are three steps. One of them is just testing for any tenderness, which I usually don't do actually, but it's in some of the books. And the other one is the for chest expansion. We start with the upper zone. Your fingers has to be on the supraclavicular fossa and has to be firm. As not pushing the patient, hurting the patient, but just firm. And the thumb, both thumbs should be free and away from the skin. Ideally, should be away from the skin. Okay? And then you ask the patient to take a deep breath in. On the first, and see the two fingers and the two thumbs is away from each other. The first. Okay. And then under the armpits, the first. So my comment would be that chest is moving equal bilateral. Nefas. And then the lower zone. Nefas. Okay. So my fingers should be holding the patient firmly and the thumbs touching each other and away from the skin, and they are relaxed. They are not tense, the two thumbs. Okay? If the patient is huge, then you can make a skin fold like this. Nefas. And my comment would be the chest is moving equal bilateral, or the right chest is moving more than the left chest, or the right side moving more than the left side, etc. Never mention the chest is moving, or the movement is 5 centimeters or 6 centimeters. This doesn't make any sense. Okay? The whole point of the chest expansion is to test whether the two sides of the chest are moving equal from midline or not. Okay. If you have a small hand, then you do not need to start from the axillary side. You can move your hands medially according to the size of your hand, and then you ask the patient to breathe in. Okay? This is about chest expansion. Third part of the palpation would be the tactile primitus. So we ask the patient to say 99 or 44. 99, please.
99, 99, 99, 99.
So the whole hand should be touching the patient.
99, 99, 99, 99.
And always compare right with left. Or you can use both hands. All are correct.
99, 99, 99, 99, 99.
You have to examine the ABC, and you have to examine or look for the axillary side for the middle lobe and lingula. Otherwise, you lose marks.
99, 99, 99, 99, 99.
Of your hand. It's not wrong, okay? But it's not. It's a screening test. Don't waste much time, and just use. I would recommend to use both hands at the same time. But you have to use the whole hand, not only the tips of your fingers, the whole hand, including the palm. Okay? Percussion. So when you do the percussion, you have to ask the patient to hug himself to get away from the scapula. So you can put the pillow, okay? So you can get away from the scapula and then can do more easy percussion. So we start percussing the upper zones, or the apices rather, or you can just percuss directly on the clavicle. Okay? Okay? And then the back. Middle finger on the middle finger. And the other fingers upwards. Okay? Compare right with left in a zigzag pattern. Do it again. Okay, and then I move to the auxiliary side looking for the lingua and middle lobe. Okay, so the percussion, there are three notes. There is resonant, which is normal. There is dullness and hyperresonance. The causes of hyperresonance are pneumothorax, emphysema, and hyperinflation, whether due to asthma, acute asthma, or due to COPD, etc. And causing of dullness, just everything else, just put this in your mind. Everything else other than these three may cause dullness, such as consolidation, effusion, collapse, mass, big mass can do that, etc. Common mistake in percussion that you percuss over the vertebrae or very close to it, like this. This is wrong. You have to be away from it. I get away from the scapula, but away from the vertebra as well. Okay? Another common mistake is that although you get rid of the scapula, but you go all the way to the scapula and percuss. This is again mistake, common mistake. The other mistake in the percussion is that you percuss longitudinally. It should be horizontal. Now the longitudinal one, it may do the job actually, but it's not the standard way. Okay? So don't expose yourself to whether you will get the full mark or not. Okay, this is about percussion. Let's move now to the most important part of the chest examination, that is auscultation. And in the auscultation there are two parts. You auscultate for the breath sounds and you auscultate for the vesicular, for the vocal premises. Now, and you start also again with you should include the apices and the middle lobe and lingula in the auscultation, and the patient has to be in this position where the scapula are away from each other. So we start with the apices. You can use the bell rather than the diaphragm because the space here is small, and you can press a little bit firm so that you get all the, so the bell will act like a diaphragm. The first. Zigzag pattern. Okay. This is the auscultation for the breath sound, you auscultate for the equal air entry bilateral and normal vesicular breath, no added sounds. Okay? If there is, for example, a consolidation here, I would say equal air entry bilateral, but decrease breath sounds over the right lower zone. Don't say low, just say zone, to be on the safe side, with bronchial breathe and maybe coarse crackles. Okay? 99.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Okay. So this is the vocal parameters. I asked the patient to say 99, and what I would hear normally is a muffled sound, as if the patient is talking in the water or below the under the water surface. Okay, and it should be like this, norm. Okay, and my job is to see if the vocal parameters are equal bilateral. That's all. Now, if this, what would cause better conduction and louder vocal parameters? Consolidation. At your level, consolidation. Okay? And everything else would cause decreased vocal parameters. And it's the same as we mentioned in the dictal parameters. Okay? Now, if you like to know more, then increased vocal parameters can also be seen at the tip of the pleural effusion when there is a patent airway, and also in retraction fibrosis, localized retraction fibrosis, you can hear also vocal parameters, louder vocal parameters. But as a medical student, I would expect you to know consolidation as a cause of increased vocal parameters. Okay. Now, when would you ask the patient to say to whisper or to say E? So you only look for these signs, which are bronchial signs or signs of consolidation, if you hear bronchial breath. If you do not hear a bronchial breath, then you do not need to ask the patient to do that. Okay? You just limit auscultation on breath sound and vocal parameters. Okay? So if we hear bronchial breathe, let's say I hear the bronchial breathe here, what I will ask the patient to say? Arba'in.
Arba'in. Arba'in.
E.
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 Okay. So if we had a consolidation, the whispered sound will be conducted very well, and that's called whispered victrology. And the E would sound like A, because the nasal component is well conducted, and that would call a gopher. Okay? But if we don't hear bronchial breath, do not need to demonstrate these signs. So let's collect the signs of consolidation include, in addition to the bronchial breath, which is the most important one, will include loud vocal parameters. The auscultatory signs include loud vocal parameters, would include whispered victrology, would include agophony. Okay? Now, when the loud vocal parameters, when the vocal parameters is clear, like if I'm talking to you right now, this would be called bronchophony. This would be called bronchophony. Not only loud bronchophony, it's called bronchophony. Okay? These are signs of, auscultatory signs of consolidation. You auscultate, which is again the most important step in the chest examination. This is inspiratory, and this is expiratory sound. This is the press sound. Okay? So inspiratory is longer than expiratory, and there is no gap. This is classical for vesicular breath, normal vesicular breath. If it is this way, this is X, and this is N, inspiratory. With a gap, this is the bronchial breath. This is the bronchial breath. So inspiratory equal to expiratory, and there is a gap. Okay? When you comment about the press sound, you say there is equal entry bilaterally and normal vesicular breath, no other sounds. Now, some people would mention good air entry. Well, good air entry depends on the patient himself. Either he cannot take a good breath, or he does not want to take a good breath, or he does not understand the instruction. How good the intake is may not necessarily be a pathology. Okay? So that's why equal air entry bilateral is a better term than good air entry or bad air entry. Having said that, sometimes in emphysema, we mention that there's a poor air entry, actually diffuse poor entry bilaterally, typical of emphysema. So the landmark for the major fissure is from T4 along the immediate border of the scapula downwards to the mid-axillary line at the sixth rib. Okay, mid-axillary line, sixth rib. Okay, so what's above that is the upper lobe, what's below that is the lower lobe. This is the midline. Okay, so when I examine the patient in the back, I examine the epicenter, the upper lobe, and the lower lobe. I'm missing the middle lobe and lingula. That's why we have to go inside. So where is the middle lobe and lingula? This is the center notch, second rib, third rib, fourth intercostal space. Is from here. This is the horizontal fissure. It goes horizontally, that's why it goes horizontal, and goes minor fissure, and go to the fifth rib mid-axillary line. Okay? Now, this major fissure will continue anteriorly to the eighth rib mid-clavicular line. Okay? Now, this area will be the middle lobe. This area will be the middle lobe, assuming this is the right side. Okay? For the sake of recording, we are assuming this is the right side. Okay? But this is the left actually. Right? Now, the mirror image to it will be the lingula. Okay? So if you don't put the cystoscope here, and a little bit more advanced here, you may miss abnormality of the middle lobe and lingula. Okay? Yeah, that's all regarding examination of the chest from the back. Now, which is more practical, not only for the exam, but even for your daily activity. We as pulmonologists, we do examine the chest of the patient from the back in our daily activity. We don't examine the chest anteriorly. One of the reasons is that we can auscultate the whole lobe by doing that. If we examine the chest anteriorly, then you are faced with the upper lobe, middle lobe and lingula, and a little bit of the lower lobe. Okay? So that's a negative point. The second thing, you have the heart and the liver, so they're not really equal sides. In addition to the soft tissues, whether males or female, that may interfere with your exam as well. Notice Yeah, just look, fine. I mean, what would you, how would you examine the chest anteriorly? Without an inspection again, we inspect for scars, just skin lesions, for cutlery marks. Take a deep breath. Equal breath sounds. As we take a deep breath, you see equal chest movement, bilateral, and you may see deformity more clear. The patient has a deformity with a deep breath. And you look for deformities, which is like pectus craniatum, pectus excavatum. You look also for dilated veins, which is important anteriorly. We can see that posteriorly. And dilated veins indicate collaterals. And we can see that in severe vena cava obstruction syndrome. And then you move to percussion, palpation. Palpation, there are four things in palpation anteriorly. You palpate for the apical impulse, you palpate for the trachea, we'll come back to the trachea later on, and you palpate for chest expansion. You do it two zones. Notice? Under the breast, okay? Two zones, upper zone and lower zone, that's all. Okay? And then you put the tactile premises, 99.
99, 99, 99.
Okay? And percussion, we skip percussion because of the heart and the liver, or you may just percuss looking for the dullness of the heart and the dullness of the liver. If you pick up the dullness in the heart and the liver, that means the patient does not have emphysema or hyperinflation. And then auscultation. We auscultate 1, 2, 3, 4 points. In the back, the auscultation usually takes L shape and about 6 points. Okay? And then when you do the auscultation, you auscultate again for the heart, for the breast sound, and you auscultate for breast sound, and you auscultate for vocal herpes. Okay. And it's the same comment as we for the back. The patient has to be straight, the head has to be straight, not upwards, not moving on either side. Because you move upwards, it will fix the trachea. So just straight like this. And then you look for three things. You look for the position of the trachea, the length of the trachea, and the descent of the trachea, the movement of the trachea with breathing. So for the position, you use the index finger, sternal notch, and move between the trachea and the sternocleidomastoid. Okay? You see the space. It's a rough exam, obviously. The space in the left and the right should be the same. Okay? If you turn the patient on the left side, if you want to know how would the patient's tracheal deviation to the left would look like, just turn the patient and let's feel it. You can see the difference in the space between the sternocleidomastoid and trachea on the right side and the left side. This is very narrow here, indicating that the trachea lip shifted to the left side. Okay? But it's not actually shifted, just the patient is moving his head. That's why his head has to be fixed and straight. Then the length of the trachea. The length of the trachea from the cricoid cartilage to the sternal notch. And it should be 5 centimeters at least. Don't clench your 3 fingers, because my 3 fingers are different than your 3 fingers. They are just 5 centimeters would be good enough. Okay? Then the movement of the trachea. Again, you put your finger, the index, over the trachea, below the cricoid cartilage, because above the cricoid cartilage there is no trachea. So below the cricoid cartilage, and you do not actually need to ask the patient to breathe in. And you can see if the patient in COPD and in stress, it will edge, it will move. It will move at the rate of the respiratory rate. And your hand has to be away from his chest, because if you put your hand in his chest and he's breathing, Can you breathe? Then you may think that your finger is moving. Is your whole hand moving because of his normal breathing. Okay? So in this we see that in COPD, and you can see that your thumb is moving up and down at the rate of the respiratory rate. Now the other word used for tracheal descent is the tracheal tongue, and this the original name used for actually an aneurysm, aortic aneurysm, pulsating, pushing the left main bronchus downwards at the rate of the heart rate, and that will push a trachea up and down at 90 or 100 times per minute, which is the rate of the heart rate. But this, for the COPD, is more the rate of the respiratory rate, 12, 16, etc. When the exam, when they ask you to do examine the chest in the back, then you do not need to include general respiratory examination. General respiratory examination is different. It's just like general examination of anything else, starting with the hands, you take the vital signs, you go to the eyes, the nose, the mouth, the neck, the lymph nodes, and etc. And in addition to, of course, the vital signs, respiratory rate, etc. So that this few important points to stress it, that when you statate, which is again the most important part of the exam, you statate with at least 6 points. 1, 2, 3, 4, 5, and 6. Okay? Obviously, if I hear abnormality here, I will go up, down, do more than 6. Okay? But this is just a screening point, if you like. The other thing is when you inspect, you would try also to inspect to mention if there is any use of accessory muscles. Okay? And you can do something extra that if you're tall enough, you can look over the shoulder of the patient and see if the patient using accessory muscles, the sternocleidomastoid, the scalene muscles, and if the patient has balled chest or not, just by looking over his shoulder. This is extra information. If you're good enough, you may add it. But it's not requested from you. But definitely was requested in the inspection. If the patient is in stress or using accessory muscles, then this should be part of your inspection as well. Obviously, it will be more detailed in the general examination if the patient is using in stress and using accessory muscles. But you should mention it when your exam is focused. When you do the tracheal examination, if you have a short trachea, this is usually due to COPD, when the patient has a barrel chest and the trachea nodes jump closer to the cricoid cartilage. In the tracheal descent, what's the mechanism of tracheal descent? The most likely mechanism is that, obviously we see it in COPD mostly, or hyperinflated chest, severely hyperinflated chest. So your diaphragm when you breathe is just like this, and when you take a deep breath, it goes down like this. Now these people, the COPD or hyperinflated chest, patient with hyperinflated chest, the diaphragm is already flat, and when they breathe in, it will go downwards, okay? And that will push or pull the mediastinum rather downwards, with them, including the trachea, and so the trachea will be moving up and down with breathe at the rate of the respiratory rate. This is most likely the mechanism of tracheal descent